So if we're going to want to adjust cardiac output, we either have to modify heart rate or we have to modify stroke volume or both. Okay, heart rate we've talked about, which is initiated by the myocardial autorhythmic cells. Those autorhythmic cells can be slowed down with parasympathetic activity, acetylcholine binding to muscarinic receptors on myocardial autorhythmic cells, which will decrease the rate of the MACs and accordingly the rate of the heartbeat as well. And heart rate can be increased by norepinephrine and epinephrine released from neurons in the adrenal medulla respectively, which will bind to beta 1 receptors of myocardial autorhythmic cells to increase the rate of MACs and, as such, heart rate. So we can adjust cardiac output either via parasympathetic or sympathetic influence on the myocardial autorhythmic cells. The other factor affecting cardiac output is the force of ventricular contraction, and the force is directly related to stroke volume. The greater the force, the greater the stroke volume. And there are two factors that impact stroke volume. One is the length of the muscle fibers before contraction. The second is the availability of calcium. The length of muscle fiber, and when I say muscle fiber, the myocardial muscle cells, is dictated by the amount of blood in the ventricles just before contraction. The more blood in the ventricles, the greater stretch of the myocardial contractile cells and the greater force of contraction up to a point. It certainly can stretch too much where the myosin heads can no longer grab the thin filaments, but we talked about this when we covered skeletal muscle, about the optimal length tension relationship. So force or stroke volume can be increased by having the optimal length of the myocardial contractile cells immediately before contraction. The second factor is the availability of calcium for the MCCs. And that can be, the availability of calcium is improved by sympathetic activity to MCCs, specifically norepinephrine and epinephrine will increase calcium availability to MCCs, which in turn will increase force of contraction. In conclusion, cardiac output can be modified by changing heart rate, either increasing it or decreasing it, or modifying stroke volume by increasing force of contraction, which is dictated either by the length of the myocardial cells or the availability of calcium, which is related to epinephrine and norepinephrine binding to beta 1 receptors on MCCs.